We'll be meeting a patient later as we introduce you at the clinical scenarios that can enhance our stroke localization and determine probable etiologies of this neurologic deficit. We'll emphasize early evaluation and management of stroke patients, and we're going to talk about latest stroke treatments and guidelines or strategies. Okay? If you have any questions, feel free to message me and we'll be able to answer it later. This is the outline of our presentation this afternoon. Okay. So, you are a freshly newly minted doctor who passed the board examination. And then you decided na maybe I don't want to go to residency first and start working in a local emergency room as a moonlighter. Okay? Personally, I also had moonlighting before I went into residency, and it's also a different science altogether. During your duties, you met a 56-year-old male. His name is Philip Hines. He's hypertensive for the past 20 years, who has been advised to take losartan but was not compliant to his medication. He's diabetic, not insulin requiring. He had no previous stroke, a 40-pack year smoker, was a cocaine user, who came to your ER with right-sided weakness. 2 hours prior to admission, he was noted to have a right-sided body weakness when he noted that during eating, he wasn't able to grab the spoon effectively. After that, he asked his wife that his right part of the body is more numb compared to the left. A few minutes after that, he had incomprehensible speech, para daw siyang nauutal, and that's why he went to consult. It's important that when you ask the history, Mr. Phillips said he had no headache, no nausea, no vomiting, and he was awake and he had no seizures. He went to your ER 3 hours prior to admission. Okay. So right now, I want to ask the audience, the studio audience. So I just want you to comment in the chat box. Do you think is the patient having a stroke or not? So just comment why if yes, sure na, mukhang stroke ito, or no, mukhang di pa to stroke. Sige. Walang tama or mali sagot at this point. Just put a yes or no. What do you think? 56-year-old male with comorbidities who presented to the ER having right-sided weakness while eating his meal. Sige. Huwag na kayo mahiya. Mag-comment lang kayo. Yes or no. Okay. So, most of us are saying yes. Syempre naman kasi yun yung topic natin this afternoon. Yeah. Okay. So later we'll be able to dissect the case and find out if he's been having a stroke or not. Stroke is actually if we have heart attack, stroke is actually brain attack. It's also known as cerebrovascular disease and is characterized by a sudden focal or global neurologic deficit due to an underlying vascular pathology. Okay, note that the word sudden here is italicized, okay, and bold and yellow. It should be sudden, biglaan, okay? The symptoms lasting more than 24 hours or persistent, and sometimes it leads to death or disability. There's no apparent cause other than a vascular origin, which we're going to discuss later, and actually is the most common neurologic problem or disorder. Again, sudden onset focal neurologic deficit. By deficits, we have different presentations of stroke. First is balance. Okay? Minsan po ba nung kumakain po kayo or naglalakad po kayo, napansin niyo ho na 'pag naglalakad po kayo natutumba kayo sa kanan na lang ho or kaliwa? Para po ba kayong lasing? Eyes? Minsan po, kayo po ba ay napapansin niyo, di niyo nakikita yung isang biglaan ho, yung isang parte ng pagtingin niyo ho or nabulag po kayo sa isang mata. Face? Napansin niyo po ba na iba na po yung ngiti or tabingi na po ang muka ni mommy or ni daddy? Arms? Is one arm weaker than the other? I usually, if you go to the ER, di mo naman tatanungin yung patient, di ba? Is one arm weaker than the other? But I actually go and ask the activities of daily living. Sometimes you ask, nung po nagkumakain po yung pasyente, napansin niyo po ba na nabitawan niya na lang po yung kutsara? Nung po naglalakad po siya, napansin niyo po ba na naiiwan na po yung kanan or kaliwang paa niya? Speech, is the person's speech slurred? Napansin niyo po ba na utal na po siya? Or very common, they ask the relatives or the family members say na parang umuurong ang dila ni lolo or ni lola or ni mommy or ni daddy. Is he or she confused or have a trouble time speaking and time, which we're going to talk about later. Whenever I introduce stroke to medical students or even to patients, I usually tell them that the brain is like a house, no? Yung bahay natin para siyang bahay. And each part of the house is connected to another using tubes or pipes. So that the water will go from one part of the house to another, from your water pump to your bedroom to your bathroom, etc. However, our brain looks like a pipe system as well. And because of that, it can be clogged or it can burst. Tulad ho ng bahay natin, ang utak po ay puno ho ng maraming pipes ho, no? Puro tubo. At kagaya ng tubo, pwede po itong malagyan ng mastakan ho or maklog or pwede rin pumutok. This analogy will also bring us to the two types of strokes. One, wherein the pipe is clogged, called ischemic stroke, and another, when the pipe burst already, called hemorrhagic stroke. Both of them are types of stroke, hence they will present with focal neurologic deficits which are sudden. In PGH, the ischemic type of stroke are more common than the hemorrhagic type, no? Or often than not, we get more ischemic than hemorrhagic. So mas marami po yung times na nababara yung ugat kesa pumuputok. If you go to other hospitals, still, ischemic strokes can be more common than hemorrhagic, sometimes 70% ischemic and 30% hemorrhagic. Under ischemic stroke, there can be two types. Thrombotic, it means that dahan-dahan na buo or little by little, the clog accumulated, or cardioembolic, it means that perhaps an embolus, like a fat embolus, or perhaps a blood clot just through from the heart to the brain, kaya cardioembolic. Under hemorrhagic, there are also two types, intracranial hemorrhage, wherein the pipes burst, and subaductoid hemorrhage, which is more commonly aneurysmal or secondary to ruptured aneurysms. The timeline of symptoms are also important. No? If you can see, in neuro, we always say that time is brain because every minute that the brain doesn't receive oxygen, a lot of neurons die, more than 1 million. Usually, we term hyperacute if the stroke happens 0 to 6 hours after the onset. Acute from 6 to 72 hours. Subacute 3 days to less than 3 weeks or 4 days to less than 3 weeks, or chronic if more than 3 weeks. Note that in order to get the timeline or the proper term, how to describe the stroke, if it's an acute stroke, a chronic stroke, a subacute stroke, you should know when the patient started feeling his or her symptoms. That's why dapat simula pa lang ngayon sa med school pa lang, when you're writing the history of patients with stroke, hindi siya few hours prior to admission, hindi siya few months prior to admission, lagay nyo. Correct, 2.5 hours prior to admission. Be specific. Because as you can see, even a change of a few hours will change the term already and also impact the prognosis of patients. If you go to the Philippines, the stroke is the second leading cause of death and actually the most common cause of disability. That's why we have to put an impact on this one. And actually, I also took the opportunity to discuss stroke to medical students because it's also one of the diseases that are commonly mismanaged. Okay? The only difference is that when you talk about TIA, it's transient. Okay? Kagaya siya ng ex mo, no? Nagpakita lang mabilis, tas nawala na. Okay? So, yung stroke permanent. Pero parehas, ayaw mo silang magkaroon. Okay? So, a TIA is an acute loss of focal brain or monocular function. So, it has similar presentations of stroke, lasting only for less than 24 hours. Technically, compared to stroke, if you do a neuroimaging of the brain, if you have a TIA, there should be no change, no? Using MRI or DWI. There are different risk factors for stroke. The older you get, the more common the stroke is. Being a male, an African American, having diabetes mellitus, having a family history of stroke, or having carotid or vascular problems. Note that having a TIA is a risk factor for stroke. No? Ibig sabihin, kunwari, may mga relatives kayo or makakilala kayo. Minsan ho, nanghihina po yung kanang kamay ko. Pero minsan lang ho, no? After 15 minutes, umu-okay na naman. Always warn that friend or relative of yours because the transient ischemic attack will always be a risk factor for stroke. No? If you had a TIA in 5 years, almost one-fourth of patients having transient ischemic attacks will have a stroke. So pag may na-catch na kayong TIA, bigla pong nangiwi yung mukha tapos bumalik po ulit. Okay? Bigla pong namanhid po yung kaliwang parte ng katawan tapos bumalik po ulit. You have to ask the patient to have a workup so that you will prevent a big stroke from happening. Okay, mag-ano tayo, question and answer portion. Kasi this is one of the favorite board exam question. Which is not a part of the virtual triad? Okay. A, stasis of the blood flow. B, endothelial injury. C, hypercoagulability. Or D, none of the above. Okay. Sige. Tingnan natin yung mga messages nyo. Which is not a part of the virtual triad? Stasis, endothelial injury, hypercoagulability, none of the above. Okay. Most of you answered none of the above. Correct. Okay. I placed this slide here because the interplay of this is one of the basic pathophysiologic mechanisms of stroke. No? Sometimes you can have hypercoagulable states from cancers. Okay. Sometimes if you have very high sugars, they say that the blood is thicker. If you have hemodynamic changes or stasis, ibig sabihin, stasis hindi gumagalaw yung dugo. For example, if you have atrial fibrillation, it means that the heart is not pumping well, the blood is just staying inside the heart, you have stasis, and then you can have a blood clot. Endothelial injury or dysfunction, for example, you have a thrombus a thrombus formation from endothelial injury. Endothelial injury can promote thrombus formation because as you can see, if there's endothelial injury, the platelets will aggregate with the formation of thrombus. If you have the three going on, you have a very high chance of having stroke. Actually, the virtuous triad is also a risk factor or also the pathomechanism to other cardiovascular diseases. The other risk factor of strokes are as follows. Hypertension, atrial fibrillation, cigarette smoking, transient ischemic attack, dyslipidemia, lack of physical activity, obesity, excessive alcohol intake, drug abuse, such as cocaine use. If you put these two slides together, the two slides about risk factors, you'll be able to note that on the right are treatable. That's why if you start working up a patient who had a stroke, always remember to treat the risk factors that are treatable as to prevent another stroke from happening. Okay. Clinical presentation. So, bibong-bibo kayo, no? Nag-duty kayo sa ER that time. Okay? We go back to our patient, and then you started doing your physical examination. And you found out that his BP was 155 over 90, his heart rate was irregular, and on systemic examination, and when you did your chest exam, there was irregular rhythm, but normal rate. The neuro exam of the patient revealed he couldn't see on the right, he had great central facial palsy, a very slurred speech, and his right is really weaker than the left. You did your reflexes and you found out that he had Babinski on the right. So you have a 56-year-old male who came in 2.5 hours, 3 hours post-ictus with right-sided weakness who had irregular rhythm and a right hemi syndrome. Ibig sabihin, may right hemi anopia siya, right central facial palsy, right hypotonia, right-sided weakness, right hemi anesthesia or numbness, and Babinski on the right. Okay, board exam question. Which of the following can present with right-sided weakness? Okay, the question. Which of the following can present with right-sided weakness? A. Stroke. B. Multiple sclerosis. C. Brain tumors. D. Radial nerve impingement. Okay. Which of the following can present with right-sided weakness? Okay, right kayo sa ano? Sa chat box. Okay. So most of you, stroke pa rin, di ba? Okay. If you can see, the correct answer is all of them. Okay. Ang daya ko, no? Okay. So all of them can present with right-sided weakness. Okay. A stroke. In stroke, you can have a right-sided weakness. In MS, in brain tumors, in peripheral nerve impingement. Because because there can be alterations in any part of the corticospinal tract. Okay? Tandaan niyo yung corticospinal tract, yung mahirap na part all sa neurology rotations natin, no? It all starts with a precentral gyrus, okay? And it will coalesce to become the corona radiata in the internal capsule, going to your middle two-thirds of your midbrain, will decussate in the medulla, called the pyramidal decussation, kaya may pyramids, and they'll become your lateral corticospinal tract before they become lower motor neuron. Okay? What I'm trying to say is that any part of the cortical spinal tract, because it is used for motor movement, can give you weakness. Okay? Let's say you have a tumor in the left corona radiata. It can give you weakness since before the decussation siya, di ba? If you have an abscess here, it can also give you a right-sided weakness. If you have plaques here, even trauma, okay? If you have an epidural hematoma on the left parietal area, you can have right-sided weakness. And if you go more peripheral, in the brachial plexus, for example, you had a gunshot wound on the right shoulder, you can have right-sided weakness, okay? If you have uh, fractures of your humerus, when the radial nerve is impinged, you can have right-sided weakness. Most of them can present with right-sided weakness. It just depends on the level of the corticospinal tract which is affected. Okay? My mnemonic, students, for when I do my differential diagnosis is vitamin C and D. Okay? I ask if it's vascular, pwede siya maging stroke, and other types of stroke, sabi natin madaming different parts pa, di ba? Thrombotic, cardioembolic, ICH, etc. I is infectious, T is for trauma, A is autoimmune, M is metabolic, I is inflammatory, N is neoplastic, and C and D congenital and degenerative. Right-sided weakness can have different etiologies. The vascular is usually stroke, di ba? And the infectious, trauma, autoimmune, and the like. Okay. Remember this slide? One thing that will make you suspect a stroke, because you have a lot of differential diagnosis, correct? Is that this? Okay. It's a very famous acronym in terms of stroke care called BFAST. Balance, eyes, face, arms, speech, and time. Okay? As I mentioned a while ago, what makes stroke a stroke is actually its onset. It should be sudden. Okay? It should be sudden. Usually, in infectious causes, you can have a history of fever, and the right-sided weakness can be progressive. Ibig sabihin, lumalaki pa lang yung abscess. Sa neoplastic din. Sa autoimmune, at trauma, syempre, you ask for history of trauma. Autoimmune, you ask for other history of possible multiple sclerosis. Is the patient young? Is the patient female? Are there other signs like optic neuritis or blurring of vision? Metabolic, hyper and hypoglycemia are very good stroke mimics and the like. What differentiates a vascular cause from the other causes is the onset. So it should be sudden, biglaan. Now that you're able to know that most of the strokes present with balance, eyes, face, arms, and speech, it's prudent to go back and inform everybody again that each part of the brain is corresponds to a different function. Correct? Diba? We have the most elementary thing that we know. We have the frontal lobe for judgment, the for judgment and a part of the motor, parietal lobe which part of is part of the sensory and also is a good association area. Temporal for listening and also for memory, and occipital to see. Okay? But if you, when you go to your med school already, you'll get to know that the wonderful part of the brain is even though it's very complicated, there seems to be structure. Like the face is found here, the hand, the arm, and the trunk, etc. So it's prudent to say if you know where the part of the brain is corresponding to the movement of the body, no? Kung alam mo na nanghina siya dito sa hand and sa arm more than sa face, you know that the lesion is here. Okay? If you know that in the history, it's just the face that's affected, you know the lesion is more lateral than medial. We will not be able to complete the diagnosis or the discussion on stroke without going to this favorite board exam question, the circle of Willis. But I'll make it more simple to everybody. Okay. The reason why the circle of Willis is circle, no? Though actually up to 20% of the population may mga hypoplastic, ibig sabihin may hindi na nabubuo. The reason why it's circle is because we have been created so smartly that kailangan natin ng backup lagi. So for example, if there is a problem here, the PCOM can compensate and the blood flow can go there instead of the ACOM or the ACA. Okay? If we go back to the circle of Willis, no, the circle of Willis will show you the part that's supplying the anterior circulation and also the posterior circulation. Now that you know that the circle of Willis and also that the brain corresponds to some sort of topography, if you put them together, you'll be able to know that if, for example, this branch is affected, which is the presentation of the patient. So, pag MCA yung natamaan, well, I think more of the face, the hand, pero less of the foot and the toes. Pero if ACA yung natamaan, it's more of the lower extremities than the upper extremities. So, one of the favorite board exam question is the homunculus, and you usually ask which is supplied by the most medial part of the homunculus, the face, the arm, the trunk, or the legs. If you're going to look there, here, marami yung face, pero nasa lateral part siya, pero yung lower extremities sa more medial. So the answer is foot or lower extremities. More often than not, when we talk about stroke, lagi lang sinasabi nila yung upper or yung supratentorial region, no? This one, di ba? However, hindi natin nakikita yung mga nasa baba, yung mga nasa laylayan. But mind you, this part is also important because if you're going to go back to your neuroanatomy, these parts, the infratentorial, are actually the cerebellum, which is in charge for the coordination, and the brainstem, which houses the different nuclei of the cranial nerves. Okay. For everybody's information, 'di ba? Kanina nakita nyo, puro weakness, puro sa supratentorial. Here, if we have a patient presenting with the Ds, okay? Diplopia, dysphagia, dizziness, and very worrisome dysarthria, a good localization as well is also the infratentorial region because, as mentioned a while ago, the cranial nerves are housed here. No? That's why even a small stroke in the brainstem or the infratentorial region can present with these symptoms. Clinically, can you differentiate an infarct from a bleed? Usually, but not always, infarcts have progressive symptoms habang tumatagal, like our patient, di ba? Nagsimula lang siya, di siya makalahawak ng kutsara, di na siya makalakad, tapos nagtautal-utal na. While sa bleed, the symptoms are maximal at onset, and you'll see a lot of increased intracranial pressure signs in the first few hours. Among all of these, headache is the most sensitive that can differentiate an infarct from a bleed. Okay. So, confident na ba kayo? So, if you go back to the patient, you think, will you consider patient PH as having a stroke or not? Sige. Pati nga sa messages. Tingin niyo ba may stroke na siya? Wait lang. Wala ata ako. Okay. Nakikita ba ako? Nawala yung connection ko sa phone.
Yes po, Doc. Nakikita po, Doc.
Okay, water break. Huwag tayo ma-dehydrate kasi mainit na. Okay. So, okay. Okay. Nakita ko na ulit. So, if the patient having a stroke or not, if we go back, diba, sudden onset focal neurologic deficit. That pa lang, mukhang we have to consider stroke right away already. Okay, sure na. So, how about this one? Most likely, does patient PH have an infarct or a bleed? Tingin niyo. Can you type sa chat box if you think kung infarct siya or bleed? Si Lester, naka-ano na. Okay. Okay. Most, di ba sabi natin, one way to differentiate an infarct or a bleed, the most sensitive is headache.
And patient PH didn't present with headache. At the same time, his symptoms was progressive. Some in the first few hours, like an infarct. No? Though not always, no, it's not a golden rule na pag walang headache, infarct na yan. Pero most of the time, no. That's why I always screen for headache in patients who come to the ER with focal deficit. So infarct, very good. Okay, now that you use your clinical acumen has been enriched already, what and you already have a working hypothesis that perhaps patient PH really has a stroke. How can we prove that he has a stroke indeed? So that's one of the questions now. That's why we'll talk about basic approach to workup. CTN member, CTN na daw ba ito, T? Okay, so this is the emergency room
Yes,
of
yes.
PGH, no? Hopefully hindi pero this is pre-pandemic. Okay, so
Maganda na ngayon, may aircon na.
ganda na may aircon na ngayon. But this is the ER of PGH before pre-pandemic, and you'll see a lot of patients. So you saw the patient in this ER and you decide what should I do to prove if the patient has an infarct or a PEEP. Okay, favorite board exam question. What is the most sensitive diagnostic modality for patients with acute ischemic stroke? Medyo level up na to. The most sensitive, X-ray, CT scan with contrast, plain CT scan, or cranial MRI. Answer tayo sa mga students. Huwag kayo matakot. Sabi ko nga always sa mga clerks and interns na nag-rotate, it's better to get wrong now as a student than in the future, in the board exam, or in the more far future when you're seeing patients already. Okay. So we're seeing a lot of plain CT scan. Okay. Okay. The most sensitive diagnostic modality is actually the cranial MRI. Okay. We're going to talk about and compare and contrast the two later. So CT scans are actually the first line imaging in suspected stroke patients. Sila yung pinaka most commonly used because it's the most readily available. It's highly sensitive in detecting hemorrhage. Okay? However, when you look at patients who come into the ER and you're considering an infarct, usually the signs of an infarct, of an obvious infarct, will not show up until 6 hours post-ictus. In contrast to an MRI, this is very sensitive to early infarction, especially brainstem lesions, diba? A while ago, I told you about the components of the infratemporal region, the cerebellum and the brainstem. The diagnostic of choice for patients presenting with the Ds is actually MRI because if you look at the brainstem, around it is a part of the skull already or cranium. And sa CT scan, maraming artifacts so hindi natin makita or ma-visualize better. However, MRIs are insensitive to hemorrhage and it's very expensive and not readily available. You'll see that a plain cranial CT scan is usually 3,000 to 5,000 pesos, while the MRIs are actually 20,000 pesos more. But technically, the most sensitive is MRI, but the one thing that we usually use is the CT scan. If you go to other countries, first world countries, sometimes if they have more time, kaya walang hinahabol na golden period, they do MRI instead of a CT scan. As mentioned, the CT scan or your computed tomography can distinguish stroke even without contrast. Remember, students, that when you do contrast study, it means that you're looking for something that will take that contrast. Ibig sabihin, if you put a contrast, may magla-light up. At ano ba yung magla-light up? Usually abscesses, bukol or neoplasm. But sa stroke, wala ka naman ine-expect na mag-light up. Okay? Ischemic stroke cannot be immediately seen in CT scan, but hemorrhage can already be seen. So, I want you to look at these two images. They are quite different, no? Okay. The red arrow is showing the infarct at this point. As you can see, one of the things that if you are going to rotate, diba, in the clinics and you have a CT scan with you, always compare the right and the left part because asymmetry is a wonderful teacher, no? That will give you an idea which part is pathologic or not. Here, the red arrow shows the infarct. The infarct is hypodense. Ibig sabihin hypodense towards the color of fluid in the ventricles. Fluid or air. Compared to a bleed is hyperdense. Mas maputi siya compared to the color of the bone. If you look at the CT scan here, no, aside from the bleed, you'll see a occasionally black uh, structure around it. This is actually your edema. That will be worrisome in the next few days. So hypodense, infarct, hyperdense, bleed. Kailan lumalabas ang hypodensity or infarct? Usually 6 hours post-ictus pa. Compare this to your MRI. Your MRI actually uses magnets compared to your CT scan, which kind of uses X-rays. Here, they using the sequence called DWI, you'll see that part of the brain will light up in acute ischemic stroke and can be a very good way to differentiate new and old lesions. Aside from DWI, there are also different sequences in the MRI which can show your perfusion status and also without contrast can give you an idea of the vasculature called MRA time of flight. Pero sabi natin, pag mas marami kang hinihingi, syempre mas mahal. So, you have to also be cost effective when requesting this imaging diagnostics to your patients. Okay, what I tell the students is that, okay, sa CT scan, di ba, density, hypo and hyperdense. Sa MRI, hypo and hyperintense. Okay? So, to remember this, density and intensity, don't be a CT scan who's very dense. Be an MRI, intense. Medyo corny, no? Pero kind of works pa rin. Okay. So, go back to your patient. You ask for a CT scan because it's so readily available. And you see that there seems to be a hypodensity in this left part of the brain. So, if you interpret the CT scan, it's as if the patient is lying down and you are on the feet of the patient. This is the right side and the left side of the patient. And if you look at the symmetry, you'll see that this area is blacker compared to the other side. Correct? At the same time, diba, usually we have sulci and gyri in the brain. But here, you'll see that the sulci are actually effaced. It means that this part of the brain is actually inflamed. I want you to appreciate right now, okay, the combination of our clinical diagnosis, right-sided weakness, our localization, and also our neurographic findings. So, at the end of the day, what I want you to learn is that what we do when we do imaging or labs is actually we want to verify the things that we found in our history and physical examination. When you ask for diagnostics, syempre hindi lang naman tayo CT scan lang and that's it, no? We have it's like answering detective story or mystery story. You want to know what happened. You want to unfold the story how this patient came to be. Hence, you ask for different laboratories that can help you. CBG's sugar can give you an idea if it's a stroke mimic or not. Okay? Can also give an idea if the patient has a controlled or uncontrolled diabetes. CBC to check if there's possible infection, is there a hypercoagulable state, mataas ba yung hemoglobin, mataas ba yung RBC, meron ba siyang thrombocytopenia kaya siya nag-bleed. Electrolytes, sodium hyponatremia, hypernatremia, hypokalemia can also present with weakness and can actually be stroke mimics. FBS and lipid profile to check for the sugar and the lipid status. PTINR if you're entertaining any problems with the bleeding. Heart workup like ECG to the echo to check for the rhythm of the heart. And also carotid duplex scan to look at the vasculature of the neck and trop eye if the patient has been having chest pain and if deemed necessary. Okay. Lapit na tayo. So, ito, next question. Favorite board exam question. What do you call that area of preservable brain tissue in patient who had acute ischemic stroke? A. Core, B. Oligemia, C. Penumbra, or D. Stasis? Yan, gamma penumbra. Very good. So we have audience members answering penumbra. Penumbra is the correct answer. I'm going to go back to this slide because this concept on different parts of the brain having different perfusion is very important for you to understand how we can save the brain from the brain attack. Okay? When you have a clogged artery, you'll see a part of the brain which is very affected compared to the others. Okay? The core is the one receiving less than 10 ml per 100 grams per minute. That means that area is not receiving almost any nutrition already. But there are part of the brain, because we have good collateral system, with the circle of Willis, which is not affected. And also, there's also the middle part called the penumbra, which is in the middle zone. They can die or they can live. So the red arrow is the core. Okay. The red arrow is very deadly. Okay. The core can expand. Okay. The red arrow will also steal some energy from the penumbra because of hypercatabolic state. And the red arrow can also, if it expands, can also push different structures of the brain and can lead you to herniation. However, you also have the pink arrow here called the penumbra, which is the salvageable part. What we have to do is rescue the pink arrow so that we can have more hope for the parts of the brain that's affected by stroke to overcome the red one. Okay? And if we're able to salvage the penumbra or the pink arrow, there's a higher chance for neurologic recovery or to prevent mortality or for our patients to die. Okay? This is also a good representation, the red and the pink arrow, no? Ibig sabihin, pag hindi natin protect ng maayos yung core, the core will expand and most of the brain tissue will die. But if we're able to save this part, the penumbra will be able to restore some neurologic functions. But the next question is how? Okay. When you see a patient in the ER who's been having stroke, it's important to first stabilize the patient, no? Useless ang pag-CT scan natin, pag-IV line natin, pag-i-examine natin ng buong-buo ng neurologic exam. If you don't check the circulation, okay, the airway and the breathing of the patient first. After that, make a good history and determine if it's an infarct or a bleed or a stroke mimic. Control the intracranial pressure, ensure nerve protection, and manage comorbidities. Okay. Right now, One thing that is emerging is thrombolysis for stroke. It's been here actually for decades, but I think this is what we should also prioritize, not only in the centers in Manila, but also here in the province. No, we have thrombolysis or what we call alteplase or clot buster to hasten the recanalization of so that the penumbra does not end up as an infarct. Ibig sabihin, you know that, di ba? In comparing the vasculature, the cranial vasculature to a plumbing system, if there's area that is clotted, you want to remove the clot. And that's what the thrombolytic agent does, no? If given within 3 hours, there's a 30% more chance to have minimal or no disability after 3 months. So if there's a clot here, if you're able to catch that the clot happened and manifested within the first 3 hours, and you're given the patient alteplase, you can dissolve the clot right away. Here are angiogram studies showing the vasculature, no? Here, there's a clot. That's why the blood will doesn't flow peripherally to the MCA territory. But once you're able to give the alteplase, you'll see that it perfused already. So it's the only approved thrombolytic agent for patients with acute ischemic stroke in the Philippines. But in the other countries, they have other medications already, like tenecteplase. Okay. Now that you know that you want to perfuse better in a patient who had an ischemic stroke, now you'll understand why we have permissive hypertension in patients who had strokes, ischemic stroke, no? You want to put the BP on the higher edge. Why? Because if you have higher blood pressure, the more blood will go and reperfuse that area that was clotted. Hence, you do permissive hypertension. However, in patients with bleed, like parenchymal hemorrhage or subarachnoid hemorrhage, we put the patient's BP to a lower end. Again, we just do permissive hypertension in patients with ischemia or acute ischemic stroke. Kumbaga, kung dun lang sa nabara, dun lang tayo mas mataas yung pressure. Okay? I hope everyone knows how to compute for the map. It's 2 diastolic plus 1 systolic over 3. Aside from BP control, which is the cornerstone, one of the cornerstone treatment for patients with stroke, we have to also target normoglycemia, avoid hyperthermia, and desaturation. Because if you have fever, it will make the patient to go under catabolic state. And of course, if the patient has low oxygen saturation, the less oxygen that will come to the infarct, the more worrisome the infarct will be. If there's intracranial pressure, we give mannitol or hypertonic saline. If the patient is intubated, we hyperventilate. Bakit? Diba? If we go back to your physiology, carbon dioxide, okay? If carbon dioxide is actually vasodilator in your cerebral vessels. Hence, when you hyperventilate patients, pinapalabas mo yung carbon dioxide. Hindi na mag-vasodilate yung blood vessel, liliit siya, mas may space yung ano natin, yung mas mag-decrease yung pressure. And if you're pushed to the wall, we have also different surgical ways to decompress the inflamed brain. Okay. Lastly, control the risk factors. Okay? Dapat natuto na tayo. Okay? Huwag na tayo magpapabudol kung na-stroke na ulit. No? So, kung infarct, if thrombotic, we start for antiplatelet. If cardioembolic, we start anticoagulants. We treat this lipidemia by giving lipid-lowering drugs. We control diabetes. And of course, we ask the patient to undergo lifestyle modification. For patients like the one that we had today, we have to refer him to toxicology and psychiatry because he had a history of illicit drug use. So PH was given alteplase at 0.9 milligram per kilogram, and actually his weakness improved. Okay, save for occasional right pronator drift. He was able to speak better after given alteplase, and he was admitted to the acute stroke unit for 3 more days. Upon discharge, since we were found out that he was having irregular rhythm or atrial fibrillation, he was started on DOAC or anticoagulant for secondary stroke prevention. 3 months after his admission, I saw the patient in my clinic and he had no deficits anymore. Okay, so for this afternoon, hope we're able to define stroke, the pathophysiology and risk factors. Okay, we were able to analyze a clinical scenario and undergo stroke localization and determine etiologies. Hopefully you're able to know how to do the early evaluation, workup, and management, and also had an overview of stroke thrombolysis and guidelines. So with that, I'm ready to answer your questions if you have. Questions ba kaya? Ayun, tama-tama. On tayo.
Doc, good
Yeah.
afternoon po.
Yes.
One question po, Doc,
Sure.
since our topic is stroke. Tapos your lecture mainly based on medical management po in patients with stroke. So how can we say, or when will we be able to say po that patients with stroke should be referred to surgery for surgical intervention po, Doc, if needed?
Okay. So very good question, as in very practical question. No? There are different parameters when we have to refer the patient to surgery. Okay? Balik muna tayo dun sa, usually, pag hemorrhage, if the bleed is more than 30 ml, supratentorial, if the bleed is more than 3 centimeters in diameter, if infratentorial, presence of intraventricular extension, midline shift, and hydrocephalus. So, yun yung parameters na I refer to neurosurgery because if those are available or those are present, mataas yung chance na mag-acute hydrocephalus or mag-deteriorate yung patient. Okay? That's for bleed. For infarcts, it depends. If you have a big infarct, the highest time for the infarct to be inflamed is usually 3 days to 5 days post-ictus. Okay? So, for example, yung patient natin, kung pinabayaan natin, pagpatak ng 3 days post-ictus, lalaki pa yung infarct nun. Okay? Sometimes, if we have what we call a malignant infarct, it means that the infarct is very big. Clinically, the patient has deteriorating sensorium, okay? And a clincher would be the eye signs. May preferential eye movement yung patient, nakatingin lang siya sa right or sa left, okay? It means that, and you're pushed already with your mannitol, your hypertonic saline, I then refer to neurosurgery for the compressive hemicraniectomy. So, kunwari, masyadong maga yung ulo, utak, pinapabiyak yung part ng bungo para makahinga yung utak for a while. Okay. So not all stroke patients are referred to neurosurgery. So we also triage which of them really needs the surgery. Also a caveat, kung subarachnoid hemorrhage, yung worst headache of a patient's life, we refer to neurosurgery for clipping of the aneurysm if there's aneurysm. Yes.
Noted po, Doc. Thank you po.
Good afternoon, Doc. I also have another question po, Doc.
Sige.
Na-mention po natin kanina yung transient ischemic attack po, Doc. Paano naman po ito minamanage po, Doc?
Okay, sige. So, that's a good question, Ira. So, how we manage transient ischemic attack? There's a grading for a transient ischemic attack called ABCD score. So, lalagay yung age, yung blood pressure, ano yung clinical findings, tapos kung may diabetes or yung patient or wala. Based on the ABCD score, we prognosticate if the patient has high risk or low risk for a stroke. Okay? It also guides us na how aggressive we're going to be with the patient. Okay? Sometimes, but not always, ginagamit yun na to decide if ma-admit or hindi. But guidelines-wise, all TIAs right now are considered as mild stroke or low NIHS stroke. Kung mga subtle stroke, saka TIA, same yung management. So we still give antiplatelets if wala tayong makitang cardioembolic cause. Okay, if malinis yung 2D echo, yung ECG, walang atrial fibrillation, we give antiplatelets and we control the risk factors.
Noted po, Doc. Thank you po, Doc.
Doc, I received a question po from one of the audience.
Okay.
Yung question po niya is, since T2 MRI is more sensitive than plain cranial CT scan in ischemic stroke, when should we consider MRI or CT scan to an ischemic stroke patient based on the golden time versus the sensitivity po ba?
Okay, sige. Very good. Okay. Ideally, if you have access to MRIs, no, if your MRI can be done right away, it can be done as fast as a CT scan. Kasi hahanapin mo lang naman yung T2 ay yung DWI sa T2, no? So, kung meron at meron din at kaya ng patient, kung nasa ano tayo, lahat pwede ibigay sa pasyente at mabilis magagawa, I'll go with the MRI. Because aside, it will also give you a lot of things na hindi makita ng CT scan, no? Subtle white matter changes, okay? Or kung makita nyo sa ibang literature, baka medyo advanced naman, yung maliliit na tinatawag tayong cortical bleeds, okay? That can also give you an idea if the patient is at risk for hemorrhage after the alteplase is given. So the question is, ako, if you can do it fast, no? And the patient has funds, or in the best scenario, I'll do an MRI. Okay. Kunwari, di ba sabi natin ang golden period for the alteplase is 3 to 4.5 hours. Kung dumating yung patient, 4 hours, 20 minutes, no? Ako, I'll go with the scan na. Bakit? I just want to know if there's a bleed or not so I can give my alteplase right away. No? So, choosing between a CT scan and MRI is like, parang siyang ano, it's also an art, no? Paano mo ita-time yung atake mo sa kalaban? Paano yung hinahabol mong oras? No? So, to answer your question, ideally MRI if you can do it faster, if if you have the resources, the patients have resources, I'll do an MRI. Pero you also have to know, no, kung minsan as a physician, you also have to weigh, tingin mo ba kaya ng patient or hindi? Kasi baka ang mangyari, instead makabili ka ng pang-alteplase, yung pera ng pasyente, pinang-MRI. So, sayang, nakita mo nga yung stroke, di naman tayo nakabigay ng gamot. Okay, so there's also an art into it.
Noted po, Doc. Thank you po. Another question po, Doc. Sent to me via PM din po, Doc.
Sige.
What are the criteria po, Doc, for discharging a patient after being managed po, Doc, with stroke?
Okay, sige. Ang gaganda ng questions ng students, very practical. Gusto ko tong group na to. Okay. Ako, what I do, and I think kahit mag-neuro kayo or hindi, or kahit ibang suspect yung pupuntahan nyo, or kahit GP, no? You have to make a problem list. And make sure that the problem list is checked already. For example, kunwari, the problem is really right-sided weakness, at least you are able to start rehab already for the patient. If the patient problem is slurring of speech, at least if the patient is stable already, you have to started speech pathology already, exercises, no? So to answer your question, number one, make sure that the patient is stable. Okay? So for example, if the patient has infarct and you did permissive hypertension already for the next 2 to 3 days, baka pag day 4 when you restart your antihypertensives already, no? At least pag uwi ng patient, 160 yung BP niya. At the same time, nakasimula na siya ng rehab. Okay? Kung bleed naman, dapat normal tension na yung patient bago makauwi. Wala na siyang headache, naka-start na ng rehab. Okay. One thing that I also do, okay, and I think it's a good practice that I tell my residents as well. I always one of the things that I check, or one of the things that's in my checklist, is that I discharge a patient if the family knows how to take care of him or her already. Okay? As doctors, 'di ba, hindi ang trabaho naman natin ay hindi lang to treat illness, 'di ba? We want to give the patient the best quality of life, the family the best quality of life. So, I always talk to the relatives and the primary caregiver of the patient of what to expect. And if makita mo na, for example, may patients talaga na ipapa-discharge natin on NGT, doon na-start na yung speech pathology or speech therapy, di siya nakakakain, and kailangan niya ng tulong, at least may relative na marunong mag-alaga. Okay? So, number one, if the patient is stable. Number two, if the checklist or of your problem list are answered. And number three, if the patient already has a good family support.
Thank you po, Doc. There's another question po,
Rob,
Doc.
may question si Honey, one
Ah,
of the Black R.
saan si Honey? Hi, Honey.
May question siya sa chat.
Sige. Chatbox. Ayun. Okay. Hi, Sir Rob. When is the earliest time we can start anticoagulant if a patient is dosed with AFib? Is there any chance that the infarct can undergo hemorrhagic conversion? And what are the possible factors that they convert? Okay, ganda. Very good question. Okay. Starting the anticoagulant or starting the anticoagulant, there's actually a relatively new study called the Diner's Rule. Okay? Diner's Rule. Kaya dinner or diner. Basta ganun yung spelling niya. Okay? Now, if you have a patient with an infarct na proven to be cardioembolic in origin, there's a timeline, no? Depending on the severity of stroke. If the stroke is very mild, okay, less than 8 NIHSS score, when you score the scoring system of the stroke, it's called NIHSS. You can start the anticoagulation day 1 post-ictus. Okay? Ang magic number dyan ay 13912. Okay? 13912. The worst strokes, those with very severe NIHSS score, okay, you have start day 12 post-ictus. Tapos sa gitna, yung moderate, 3 or 9. So that's what guides us right now, no? Agree? Possible risk factors that they convert. Comparing a cardioembolic and a thrombotic infarct, cardioembolic strokes have the propensity to convert more than thrombotic infarct. At makikita nyo yan sa pathology lectures natin or ninyo before. The difference of a red plaque and the white plaque. Diba? The cardioembolic strokes, they have the propensity to convert. Other risk factors for hemorrhagic conversion. Okay. Very common is diabetes. Okay. So, ang gusto ko malaman, 'di ba, paano ba ano ba yung ba't nga ba nagko-convert? Ba't nga ba nagko-convert nagkakaroon ng hemorrhagic conversion? Okay, if you look at I always kun use my pentel pen. Kunyari may pentel pen kayo, 'di ba? Or meron kayong blood vessel. And the blood flows here to the other side. Okay? And you found out there's a clot here. Okay? Siyempre, malalaman natin if there's a clot here, this part of the brain will be infarcted, correct? Okay. Ito yung may stroke, no? We always think that it's just the brain tissue that's infarcted. Iniisip natin, ang hindi nalalagyan ng nutrients ay yung brain tissue, di ba? Kaya nga siya na-infarct, di ba? But come to think of it, even the blood vessel also needs nutrients. Okay? So this blood vessel is also dying. So what happens is, hemorrhagic conversion is actually when there's reperfusion and this blood vessel actually is not strong anymore. It's not just na dumudugo yung brain parenchyma, it's also because the pipe holding the blood is also weak because it's also infarcted. Kaya ka nagkakaroon ng hemorrhagic conversion. That's why the fluid or the blood goes out to the brain parenchyma. So that's one way to under why. And in connection to your question, if you have diabetes, wherein it also attacks the blood vessels, diba? It makes the blood vessels more friable and more at risk for hemorrhagic conversion. Okay. From Lester Sigabo, when do we give or what are the indications prior to giving stabilizer meds? Lester, are you talking about the alteplase, the clot buster, or by stabilizer ba? It means na you want to stabilize the plaque with statin agents already. Yung clot buster ba?
Ay, hello po, Doc. I have an experience on ICU po kasi, doctor, that one of the management to possible ischemic stroke po, Doc, especially if the patient has a related disease po, Doc, on hypertension and with the history of smoking po, Doc. One of the causes of this is your plaque po, Doc, the rupture of the plaque po, Doc. And I was just curious po, Doc, if when do we give your plaque stabilizing meds po, Doc?
Yung alteplase ba? Yung kanina? Or
At statins po, Doc.
statins. Okay. The statins are usually given to ischemic strokes. Okay? All ischemic strokes are given statins except for the young ones na hindi talaga dyslipidemia yung risk factors. For example, you have a 19-year-old patient with rheumatic heart disease who had a stroke. Baka yung cause as dyslipidemia, hindi siya ganun high, no? Kasi baka dahil sa valvular heart problem niya. But other than that, especially ischemic strokes, there's a study called Sparkle Trial wherein they start statins like atorvastatin, high dose, 40 to 80 milligrams per day. Okay? Ako, I follow the trial, 40 to 80 milligrams of statins. If the patient has ischemia, I start that. Okay? However, always keep in mind that statins or any drug can also have different side effects. So usually pag mga very elderly patient, no, they can undergo myalgia, no, minsan nagka-cramp sila. So I tend to go lower if their dyslipidemia naman is not that worrisome. So I can go to 20. Okay? So to answer your question, Lester, almost all ischemic stroke patients, we give statins, okay? But then, as I said, diba, we also taper given the results of the lipid profile. That's why we also request that while the patient is admitted.
Thank you, Doc.
Welcome.
Doc, sorry. Question lang po with the use of alteplase.
Okay.
If I'm not mistaken, Doc, may certain NHS score po before parang pwede mong gamitin yung Altiplate. What if po the patient's activities of daily living is affected pero yung NHS score niya is not parang hindi niya po na-achieve yung certain score needed to start your Altiplate. Kunwari hindi po siya makalunok, ganun, would you give your Altiplate po ba or not?
The answer is yes. So even though it's not a hard and fast rule na dapat mataas yung NHS score. For example, if you have a patient na NHS 2, ibig sabihin ba, di na siya bibigyan ng chance? Bibigyan pa rin natin siya ng chance. Okay? So, for example, kunwari, singer. Singer siya. Tapos, nauutal siya magsalita. Slurring of speech lang. Tapos, nakita mo sa MRI, meron talagang small stroke. I'll still give Altiplase. So, it's a case-to-case basis. But, that's why you have to know the functional capacity of the patient. Like, ano ba yung trabaho niya? Kasi for example, kunwari, patient ay, sabihin natin, ano yung very chill na trabaho? Very chill na trabaho. Sige, Azet, ano bigyan ng very chill na trabaho?
Wala po maisip na chill na trabaho.
Sabihin natin, hindi siya ganun ka-debilitating na deficit. Sabihin natin, meron lang siyang 10% numbness, no, on the left side of the body. Sabihin natin, the examine, 5% numbness lang. Okay. Tapos the patient came in pa around 4 hours 15 minutes post-ictus. So I start to weigh the pros and cons, no. Baka no need naman at this point. And by that time, so NHS 1, tapos almost tapos na ng golden period, baka mamaya mas mag-risk pa for bleeding yung patient. Okay. So you always have to check the risk and benefit ratio. Pero ang sagot doon ay bibigyan natin siya ng chance as in.
Noted po, Doc. Thank you po.
May questions pa kayo?
Parang everything's good na po, Doc. I haven't had any questions via PM then.
Yeah. Kung may question kayo, you can message me, email me, rj@yahoo.com or follow follow me in joke lang. Or you can also message me in Facebook. I think sa neuro or sa strokes, it's basta alam nyo how to identify, okay, a stroke, that's more than enough, no? Kasi minsan ang problem natin, lahat na lang ginagawang stroke, no? Minsan hypoglycemia, stroke agad. Di gising na pasyente, stroke agad. Yung pala pre-eclampsia, stroke agad. It's sudden onset focal deficit. That's what you have to keep in mind. Of course, marami pa rin maraming exception to the rule, and it will take more than a few hours if we're going to elaborate the different types and the subheadings. But I think as a future doctor, as long as you're able to manage, to witness and identify and basic management, that's very good already. Okay? Sige. Okay. Okay na tayo?
Thank you po, Doc. Yes po, Doc. Before we end po, Doc, I would like to call on Dr. Ira po, CASCA 2% and the certificate and registration po, Doc.
Ang social naman nito, T. Sabi ko sa'yo, chill lang. May certificate pa.
Magpapadala din sila ng sa'yo, Rob, ng bagnet.
Ay,
For stroke.
Chill lang kayo guys. Na-enjoy ko naman tong natin. Itong ating session. Saka you presented very nice questions. Yay!
So, kita na po ba yung screens ko, Doctor?
Yes, kitang-kita.
Opo. So, allow me to read the citation po, Doctor. Republic of the Philippines, Marian Marcos Memorial Hospital and Medical Center, City of Batac, Ilocos Norte. The Certificate of Appreciation is proudly presented to Dr. Robert Joseph C. Sarmiento for his invaluable insights, experiences, and expertise shared with the participants in the neurology lecture series entitled Stroke Basics, Anatomy, Physiology, Pathophysiology, and Clinical Pearls, given this 19th of March 2022 in the city of Batac, Ilocos Norte, Region 1, Philippines. Signed, Ira Cassandra S. Castro and Azen Roel G. Rabano, representatives for the PGI and junior interns po. Thank you po, Doc.
Kinukuha ko na yung certificate. Sana makabisita ko dyan sa Batak, sa Ilocos Norte. Matagal na ako sinasabi ni Tian pumunta dyan eh.
Rob. Sisend namin yan sa'yo.
Kinukuha ka na. Okay guys, sige. If you have no more questions, thank you very much. I'm really happy to spend this afternoon with everybody. Alam kong yung iba ay pag Saturdays ay nagre-review, tama ba, T? May review.
Yes. Meron silang review.
So all the best in your in your future endeavors and good luck.
Thank you po, Doc. And special thanks din po to Dr. Padre po for organizing this event po, Doc. Thank you, Doctor.
Okay, bye-bye. Sige. Ingat kayo.
Thank you, Rob.
May pa tayo ng debate ng alas 7. Okay.